Bismillahirrahmanirrahim. Iyyaka na'budu wa iyyaka nasta'in. Allahumma salli ala Muhammadin wa ala ali Muhammadin wa barik salli alayhi. Dear colleagues, I am Dr. Sultan Ayub, working as a radiologist. This is male patient, almost 50-year age, with history of indigestion and abdominal discomfort. So I am going to scan the abdomen. This is the liver, which is heterogeneous and coarse in echo texture, and this is the ascites. And this is the gallbladder, which is thick-walled, and this is the hypoechoic spaces within the wall. This is the edema. So thick-walled gallbladder with pericholecystic edema, and this is the sludge within the gallbladder. So liver is coarse in echo texture, ascites, gallbladder is thick-walled with pericholecystic edema, sludge. So basically this is the case of cirrhotic liver. Patient is unaware, and this is the portal vein, which is dilated. It is almost 15.8 millimeter. And this is the waveform of the portal vein. This is not this one, and we can appreciate that there is a significant compromise in the variation in the respiratory phase. During the expiration, the normal waveform of portal vein is there is a spike in this way, then smooth, then spike. This is called the respiration or respiratory phasicity. So there is a significant compromise in the respiratory phasicity of the portal vein. So the portal vein is dilated, and it is showing significant compromised respiratory phasicity. So I am going to check it at the linear probe, which will give us a better visualization of the liver. And here you can appreciate the liver. This is the left lobe of the liver. Here you can appreciate the surface of the liver. This line is coming straight, then there is a deviation in the line, then upward, and then smooth, then deviation, and then deviation. So this is we can say the irregular surface margin. So this is also the hallmark of the cirrhotic liver. Just like the mountain in the mountain area, we can appreciate the upward, downward, upward, downward, and look at the liver echo texture. This is significant coarse and nodular appearance. When there is a nodularity present within the liver, there are more chances to develop the hepatocellular carcinoma. Now I am again going to use the convex probe. When the cirrhosis is gradually increasing, it also affects the velocity of the portal vein, which should be above 15 to 16. Below this is the low velocity of the portal vein. And this is the velocity of the portal vein, which is almost 9 centimeter per second. This is a very low velocity of the portal vein. So it means when the velocity is gradually decreasing, this results in the portal hypertension. When the portal hypertension occurs, then there is the back pressure to the portal, from the portal vein to the splenic vein, and then splenic vein is also enlarged, and also the spleen is enlarged due to the backflow of the splenic backflow of the blood into the splenic vein. So I am going to check the spleen. This is the spleen, which is also enlarged. And this is the splenic vein, whose diameter is also enlarged. It is also dilated. So there is a backflow to the splenic vein, that resulting in the splenomegaly. So this patient is having in detail cirrhotic liver with signs of portal hypertension that is characterized by the coarse nodular liver with irregular surface margin, thick-walled gallbladder with pericholecystic edema, ascites, and splenomegaly with decreased forward. Still it is a forward flow of the portal vein, so decreased forward flow of the portal vein. This was all about the cirrhotic liver, how to describe and how to evaluate the cirrhotic liver with its associated complication. So this is basically the case of cirrhotic liver with portal hypertension. Always use the linear probe while assessing the liver cirrhosis. Its coursing, its nodularity, its surface margin. Thank you very much.